Hi, everyone. My name is Geeta Gupta. I'm a pulmonologist and sleep doctor, recently joined the faculty at Johns Hopkins. And, I just have to say, it's been so inspiring and incredible to hear from the parents and from clinicians and researchers about the advancements in sleep and LGS and everything that you're doing. So I'm grateful for the invitation. And I'm going to talk to you about characterization of sleep in children with Lennox-Gastaut syndrome. I have no disclosures. And before we talk about sleep, I want to acknowledge sleep is one word, but it comprises of so many different things. Some people, when they talk about sleep, they think about total sleep time. Am I sleeping enough? Am I sleeping too much? The physiologic sleep stages, circadian rhythms, which are patterns in sleep, breathing during sleep, which is a lot of what I do clinically, movements during sleep that can be restless legs, but that can also be abnormal movements, especially during REM sleep, which is our dream sleep. Alertness, sleepiness, nightmares and dreams, that can be a big focus for some people. REM physiology and sleep behaviors. What can disordered sleep lead to? Well, if we have disordered sleep, we can be too sleepy during the day. Sometimes it's hard to fall asleep, that's insomnia. And sometimes impaired sleep, due to a variety of reasons, can lead to fatigue. So that's brain fatigue, body fatigue. You just feel like you're dragging throughout the day. We can lead to abnormal sleep behaviors. I'm sure many of you have experienced your child or know someone who's had difficulty falling asleep, refuses to fall asleep, or falls asleep and wakes up in the middle of the night and has their own private party at 3 a.m. I've heard a lot about those. And impaired sleep can impact our whole body from head to toe. So our brain, we talk about insufficient sleep leading to increased seizures, impacts on memories, different types of seizures being more common during sleep or a certain part of the night. And then something that I focus on a lot is how does impaired sleep lead to changes or aberrations in breathing? Are we able to blow off the carbon dioxide in our lungs? How does that impact the way that our organs remodel? That can, impaired sleep can lead to irregular heart rhythms, both during sleep and wakefulness, which is a really important thing, hypertension, changes in our metabolism, and so on. So now I'm going to shift my focus to the sleep of children with Lennox-Gastaut syndrome and talk about some things that I've been interested in. We know that sleep disorders and circadian disturbances are very problematic. They're highly prevalent in children with LGS. We know that sleep deprivation can lead to increased seizures. Insufficient sleep can reduce the quality of life both for the child and the family. And despite all these problems, we still need to study. There's so much we need to learn about the sleep of people with LGS. But to do that, we first have to know, how do we measure sleep in children with LGS? And this is a question that I sought to answer with generous funding from the LGS Foundation. And basically, we performed a pilot study where we aimed to recruit at least 15 people and have people participate in various sleep modalities for at least 4 weeks. There was a 2-week and 4-week off-ramp, as you can think about it that way. We asked, will you at least participate for 2 weeks? Okay, well, if you're gonna do 2 weeks, will you at least consider doing 4 weeks? And people were able to drop out at any time. People were offered 5 different modalities, a home sleep apnea test. We used the WatchPat-1, which is a small wrist-worn device. It's disposable, it's cheaper than many of the other ones out there, and it uses peripheral arterial tonometry, which is basically measuring the change in amplitude of the capillaries to estimate autonomic activity, which is a consequence of sleep-disordered breathing, as opposed to the flow-based devices, which look at airflow at the nose, mouth, and effort bands at the chest and abdomen. Everyone was offered an in-lab sleep study. They were invited to take part in sleep questionnaires at baseline, so 0 weeks, 2 weeks, and 4 weeks. And the reason for that is I've heard from many parents that they say, well, my child's sleep is one way, say at the beginning of the month, and their sleep characteristics might be totally different in the middle of the month or near the end of the month. People wore an Apple Watch daily, performed a sleep and seizure log daily, and we obtained parental feedback as well. And so the aims of the study we had two aims. The first aim was to determine which combination of these modalities would be the most feasible and rigorous. Number two, we aimed to determine the feasibility of collecting longitudinal sleep data in the home environment for days or even weeks. And so that included sleep, like I said, sleep diaries, data from an Apple Watch, and then importantly, we wanted to see how long can people tolerate using these devices, how long will they put up with us asking for information again and again and again about their child's sleep. So 32 families consented to the study. 18 of those families agreed to the 2-week study period, and 10 remained out of those 18. 14 people agreed to be in the study for 4 weeks, and 6 remained. So I would say about half or a little over half remained in the study for whatever study period they determined was acceptable to them. On average, the child's age was 12 years, and half were boys, half were girls. Now I'm going to talk about completion and perception of the sleep assessment modalities. Of the 32 participants, 10 people agreed to one sleep study, 10 people completed the sleep study, 16 people agreed to do one home sleep apnea test, and 15 out of the 16 completed the test. And unfortunately, one of the children passed away during the study period, so they were unable to complete the home sleep apnea test. 32 participants consented to the biweekly, so i.e. every 2 weeks, questionnaires. And so we had the most number of people complete the questionnaires at baseline, and that dropped off as the course of the study progressed. 16 participants consented to the daily Apple Watch, and this was interesting to me. The percentage of days worn in the study was 89.3% on average. In contrast to the daily sleep logs, where only 52.7% of the time did people actually complete the sleep and seizure logs. So I would have thought it was the opposite, since asking a child with LGS to wear a device on their wrist that they're not used to for up to 4 weeks, to me seemed like a problematic thing potentially, but it seemed like the sleep logs were more problematic. So even though there are a high rate of completion of both the PSG and home sleep apnea test, we found that less than half of the home sleep apnea tests were technically adequate when compared to in-lab polysomnogram. And in reviewing the data, the good tests that we got were very good quality data. The parents of the children with LGS did an amazing job keeping the device on. It was really great to see the very good quality data. However, the tests where we did not get good quality data, it seemed that the finger probe wasn't on far enough, and so the sensors, the pulse ox sensor, the PAT sensor, that's at the tip of the probe, and that's why we didn't get good quality data for those technically inadequate studies. 15 people did at least 3 modalities or more, and 4 people did both a home sleep apnea test and in-lab sleep study. Interestingly, people preferred the watch PAT the best. Not surprisingly, people preferred the in-lab sleep study the least. And the questionnaire-based modalities were in between, and home sleep apnea test was also one of the least preferred option. So now I'm going to talk about perceptions of the sleep assessment modalities. In general, the questionnaire-based tests were perceived to be fairly accurate and easy. The Apple Watch device was actually very well tolerated. It was comfortable. It was deemed more convenient than the in-lab sleep study. And this is in contrast to the Apple Watch application, so the software we use to extract the data, that was less convenient for parents. Perception of in-lab PSG compared to the home sleep apnea test is what I'm showing here on this slide. And interestingly, people thought that the home sleep apnea test was more accurate than the in-lab sleep study, even though it has far less sensors. So I interpreted both. I will say the in-lab sleep study was actually more accurate, but parents perceived the home sleep apnea test to be more accurate. And the reason for that was that children were sleeping more in their natural state, how they actually sleep at home versus in an agitated condition and in a totally different environment. Interestingly, the home sleep apnea test was considered to be almost as time-consuming as the sleep study, but it was also considered to be more convenient. So to conclude, families of children with LGS are able to use an Apple Watch and complete questionnaires longitudinally in an ambulatory setting. The home sleep apnea tests are considered more convenient than in-lab sleep studies, and it may be technically feasible to use them in children with LGS. And the ideal, if we were to design a longer study, a bigger study, it's possible that we might be able to have children longitudinally be assessed for up to 2 weeks, but we have to investigate this further. Now I'm going to talk about the measures of disordered sleep. The sleep questionnaire that we asked families to fill out at 0, 2, and 4 weeks was the Children's Sleep Habits Questionnaire, which assesses a variety of sleep domains, and it was validated in typically developing children, but is used in research for all sorts of children. Abnormal is considered a score of 41, and we see that across the board, both throughout the month that children were in the study, they had abnormal scores. But as anecdotally described by parents, the distribution of these sleep questionnaires, the scores, was different throughout the month. And I saw that for all the different domains: bedtime resistance, sleep duration, sleep anxiety, nighttime awakenings, parasomnias, which is irregular behaviors during sleep, excessive daytime sleepiness, and sleep-disordered breathing. So even though the scores were typically abnormal, the distribution across time was different. And that, again, echoes what you all have been saying, which is even though your child's sleep is abnormal, it's different throughout, say, for example, a 1-month period. Parents also filled out a pediatric sleep questionnaire, which assesses sleep disordered breathing characteristics for research purposes, and about 60% of those scores were abnormal, also suggestive that probably there's a fair amount of sleep disordered breathing that needs to be addressed in children with Lennox-Gastaut syndrome. So now I'm going to shift gears and talk about a comparison of the home sleep apnea test to in-lab sleep study. We know that home sleep apnea tests are not, for clinical purposes, not used in children, and there are a variety of limitations. But there's also a lot of promise that if we can get home sleep apnea testing in the home, it could prevent families from having to come into the sleep lab, prevent children from having to disrupt their sleep schedule, and hopefully increase access to children who have LGS. We had 3 good comparisons available in this pilot study, and so on the x-axis, I have the PAHI, which is basically the number of sleep disorder breathing events divided by the total sleep time. And then on the y-axis, we have the same index for the in-lab sleep study. 2 of the sleep studies, so the one on the bottom left and the top right, had fairly similar values, and the one which was surprising because the general belief is that it's children with epilepsy may not be they might have to be excluded from home sleep apnea testing because you need EEG data to determine whether a child is having an apnea, which means you don't breathe during sleep. Is that due to seizures, or is that an actual sleep disorder breathing event? But surprisingly, these 2 tests, so the one on bottom left and the one on the top right, showed that even despite that EEG activity, the home sleep apnea test and in-lab sleep study result was quite similar. The cluster of points on the bottom right show that the home sleep apnea test had a much higher index of sleep disorder breathing compared to the in-lab sleep study. And that might be because the child slept for a longer time at home, so you had more recording time to capture the sleep disorder breathing events. When you sleep for longer, you're more likely to go into REM sleep, which is when sleep disorder breathing is worse. So this is something we need to look into further. Now I'm going to shift gears and talk about sleep schedules and circadian rhythms. These are data that we're still analyzing, so I'm going to give you a little sneak peek of what we're, kind of just a broad picture of what we're doing so far. So this is a sample of a sleep diary that we collected. To orient you to the colors, blue is sleep, gray is wake, orange is unknown, and the white is just missing data. And parents were asked to tell us every day at 4 p.m. recall your child's sleep over the past 24 hours, and they were invited to check awake, asleep, or unknown for each hour of the day. And as you can see here, there is a lot of unknown, and that's reasonable. You don't know every hour of the day if your child is awake or asleep. The sleep periods are irregular, so in general, the child seems to be sleeping at around 10 p.m., but not always, and they're missing gaps throughout the night. This is another one where there seems to be more known data, perhaps more periods of consolidated sleep. The total sleep time is about 10 to 11 hours, which is consistent with a mean age of 12 years. But there are gaps. That second day, the child was awake for a significant portion of the night. Some of the days, the child is sleeping earlier. There's also, we got some data where the parent didn't fill out the sleep log at all. And then this fourth example shows a shorter total sleep time, perhaps more consolidated sleep, but still an irregular sleep-wake pattern. So based on the preliminary observations, there are variations in total sleep time within participants and between participants, and inconsistent sleep schedules. But we need more than just sleep logs. They're unreliable, there are issues with recall and completion, and you need objective measures to corroborate the logs. Typically, actigraphy, which is a medical grade research device, is used to corroborate sleep logs, and it uses movement data as well as light data to estimate sleep. However, children with LGS, sometimes when they're awake, they're in a wheelchair, they may not be moving around a lot. So does that mean that they're asleep? No. Similarly, when they're asleep, they may be having seizures and moving around in bed. Does that mean they're awake? No. So there are potential pitfalls with actigraphy, and we have to think about using other devices such as wearables, commercial grade, and research. So we also, like I said, used an Apple Watch, and we are hoping to use this based on algorithms created by Olivia Walsh, published in 2019 in the journal Sleep, to estimate sleep stages, potentially. We have pilot data from 10 typically developing children where with high specificity and sensitivity, we were able to estimate both sleep, wake, and REM and non-REM, and then circadian metrics too. So that is an exciting next step for us. So shifting gears, so now we know potentially, we're starting to answer how can we measure sleep in children with Lennox-Gastaut syndrome? What are types of questions we can ask about the people of sleep with LGS? So many, but to name a few, can we look at the association between sleep architecture and neurodevelopment and seizure severity? Can we look at the association between circadian rhythms and sleep behavior, seizure severity? Can we treat sleep disordered breathing and see if there's an association between sleep consolidation, sleep behavior, seizure severity, arrhythmias, hypoventilation? And can we look at the sleep of children with LGS and see how that impacts caregiver sleep? So next steps in future directions, I think, have to be focused on figuring out how to assess sleep physiology, circadian rhythm, sleep disordered breathing at home. The LGS Foundation already is working with Beacon Biosignals and Longboard to look at such devices, and they've found that sleep of children with LGS impacts caregiver sleep. They found that there is reduced REM sleep in children with LGS, which is an exciting direction. Can we perform clinical trials which involve sleep interventions? Can we perform clinical trials which involve sleep as outcomes? Both very interesting. And the previous talks have also talked about biomarkers being a target for intervention, but also a signal for disease presence or disease severity. So for example, could REM sleep be a biomarker for the presence of LGS or epilepsy? Our group did a short pilot study with cross-sectional design that showed that the reduction in REM sleep was associated with a absence or presence of epilepsy. I'll go back. Another biomarker potentially could be, though it's not showing up on the slide, but that's okay. Another biomarker potentially could be circadian metrics. So, this is a big target in a lot of endocrinology research, where both the circadian metrics are used as an outcome, but also an intervention. So for example, eating late leads to obesity, but shifting the circadian rhythm can also reduce obesity and improve other metabolic markers. So can we do this in the study of LGS? And then very importantly, what is important to you? And I think in the breakout sessions, that's something we'll be talking about, generating ideas about how we can study sleep and address questions that are important to everyone in this room today. And obviously, I couldn't do any of this work without the research participants, my mentors, the consultants, when I was a fellow at the University of Michigan, all of the staff, and then, of course, the generous funding of the LGS Foundation. And that concludes my presentation. I'm happy to take any questions.
Mine was just more a comment, which is if you end up using the Apple Watch sleep detection, people may not be aware, but the FDA has approved the Apple Watch now for seizure detection too, because it's the most reliable seizure detection wearable out there currently. And that's improved. It's a monthly payment plan. It's just a simple doctor prescription to get that and get rolling. So you could do both in the same device now.
Wow.
Hi, I'm curious. The PSG doesn't just look for apneas, and when you looked at the PSGs, did the readers, if they looked at it not knowing what the patient was, did they see any insights in terms of the stages of sleep and what's going on with their sleep beyond potentially sleep-disordered breathing in the PSGs?
So to clarify your question, are you asking if we used sleep, the features of sleep to describe what was, what do you mean by what is going on, I guess?
So how they're moving between stages of sleep. So there's other sleep disorders, and obviously with what's going on in the brain, there could be other impacts. So beyond sleep-disordered breathing, how are they moving between stages of sleep relative to a sort of a healthy, normal individual? If you gave their blinded PSGs to a reader and didn't tell them what they had, would they come back and say this person has a sleep disorder? Would their patterns be different than what you see in a healthy normal?
I see. Yeah. So I was myself and one of my colleagues. We interpreted the 10 PSGs. So we knew that these children had LGS because they were recruited that way for the study. But so, yes, you're right. The interpretation of sleep studies typically focuses on the absence or presence of sleep disorder breathing because that's what the PSG was designed to do. Like, that's the clinical question it answers. However, I will say just subjectively, having read those studies, most of the EEG was atypical or abnormal. Even in the absence of seizures, there was typically disorganized EEG, and that's from a global perspective. The sleep stage composition, that's something that needs to be more rigorously analyzed, but it seems that these children have less REM sleep. And then I'll also say, in analyzing the sleep studies and EEG, the disorganized sleep architecture makes it difficult to assess whether a child is having sleep apnea or not, because many of these events are arousal based, but if the EEG is already disorganized, sometimes it's difficult to determine if there is an arousal or not. So in my limited experience, the severity of sleep apnea can be either underestimated or overestimated, because, well, typically underestimated, because it's hard to determine is the EEG signal that we're seeing, is that an arousal or is that disorganized EEG? So I think that maybe 75% answers your question.